Good afternoon, everyone. Hope you're enjoying your lunch. Welcome to this session on Reducer. There are some key factors that we want to bring across to you in this hopefully interactive session. We want to bring the challenge of angina, which we all encounter on a regular basis, back to a patient level. The patients are the ones who suffer from this. How do they suffer from it? How big a problem is it? I think intuitively we know it's not a small problem. Then we want to explore this innovative treatment. How does it work? What is the data behind it? How can we bring some of these questions to life? How can we address the questions that you'll bring to the table? And we've got a fantastic group of dedicated physicians who've been working very hard to make this session as good as it can be. And thanks to Felix Wojcik, who's going to be my co-chair, Ranald De Silva, who's really done a stack of work and research which has really informed us in this space. Mariusz, that's my best Polish for you, Tomańczyk, is going to bring to us how to actually do a reducer. And of course, we've got Tommaso Gori, who's also going to bring this session to life and make it as interactive as possible. So thanks for committing your time to it. Without further ado, we're going to start with Ranald, who's really going to drill down to the challenge of refractory angina. How prevalent is it, and how does it affect people's lives? Ranald, over to you.
Lovely. Thank you, James, and thank you for the organisers for putting together this important symposium. So really my job now is to set the scene in terms of what's to come, in terms of identifying what the unmet need is for our patients, and to then let my colleagues talk about the solutions and the evidence base to support this proposed solution. Angina is probably one of the commonest symptoms that we see in our everyday clinical practice, and it is the commonest clinical manifestation of coronary artery disease, with an estimate of around 100 million people living with angina worldwide. And of course, it's important to say that this is not a condition that is restricted to the developing world, but the developed world. This is something that is really a global issue. And this is a fairly conservative estimate of around 10% of these patients continuing to live with significant life-limiting angina despite patients being administered either conventional medical or revascularization therapy. So this is a big clinical problem. And the problem is going to grow. The prognosis of ischemic heart disease is improving, so survival is getting greater. And in addition, patients are getting older, and therefore the burden of patients with complex coronary disease and continuing symptomatic angina is only going to grow. So if we think about a patient-centric approach, this is our patient with symptomatic angina. We know from a number of pharmacological studies and registries that the presence of angina seems to be associated with an increased risk of adverse cardiovascular events. However, we also know from important work from Tim Henry in Minneapolis when he was there from the Optimist Registry that these patients continue to live with their angina, but they don't die of it, with actually 75% survival at 9 years, which was significantly greater than we previously thought. So what that means is that people are living with their angina, and they're not dying from it, so they really have a rather miserable existence with these life-limiting symptoms. So we often take angina, we listen to our patients about the symptoms that they are complaining of, but we never really put ourselves in their shoes in terms of the way that angina impacts the way they live their lives on a daily basis. And it impacts their physical activity, their personal relationships, their family relationships, and of course, this incurs significant psychological comorbidity. So adding to the burden that the patients experience on a day-to-day basis. And this has a significant impact on our health economy. So we know that patients with symptomatic angina account for around 1.5% of our total healthcare spend, that the presence of ongoing symptoms increases that even further by almost twofold, and they are often attending their primary care physicians, they're attending urgent care centers or the emergency department. And if they do get hospitalized, the hospitalizations are often of longer duration. They incur significant additional investigation, which is often invasive, and that only extends the cost of the care of these patients, but the treatments that they're administered often make little difference to their future clinical trajectory. So when we think about the management of angina and coronary artery disease, we're focused on clinical trials and the endpoints of improvement of physician-adjudicated symptoms, failure rates from various revascularization strategies, and considering what types of pharmacological revascularization strategies we would employ for the management of these patients. But that is quite different from the patient view, who they're much more interested in what are the things that I can do on a day-to-day basis. So the question is, what solutions can we offer to improve the patient experience of angina? Now, of course, we take a very reductive stenosis-centric view of the management of ischemic heart disease, and that stenosis leads to various forms of dysfunction of the coronary circulation, blood supply to the heart, and the myocardial sequelae of that, ultimately leading through the ischemic cascade to the presentation with angina pectoris. However, we need to understand that the pathophysiology of angina is far more complex. Number one, it's not just the epicardial coronary artery stenosis. We have to understand the effect on the microcirculation, the interactions between the heart muscle and the microcirculation leading to flow, and then the perception of angina by the patient. And so we need to put all of these complex bits of sources of information together, leading to the patient actually developing their symptoms, and then also the levels of dysfunction that we're able to detect by various different means. So if we think about the things that a patient is doing on a day-to-day basis, we say, and patient objectives, actually they've got very simple objectives. Can I get about doing my daily activities? And we often find that things that they want to do, which are relatively simple by our standards, are often not able to be achieved because of limiting symptoms. So I'd like to personalize this for a patient who has come to my angina clinic. And we run a large clinic that looks after these patients with difficult symptoms. And her goals were simple. I want to be able to walk my dog. I want to be able to work. She came from, a position where she needed to contribute an income to her family, and the inability was a significant source of stress for her. And she wanted to help with the care for her grandchild. Now, the thing that I wanted to emphasize is this is not a problem of the elderly. This lady was a 38-year-old woman. Okay? And she was taking GTN between 2 and 5 times per day, with multiple previous attendances in the emergency room and unable to do the things that were listed here, leading to significant physical limitation and psychological limitation. Now, this young lady had multiple previous risk factors and aggressive coronary artery disease that had previously been treated by revascularization, and a host of other comorbidities occurring at a young age. And her symptoms were persisting despite the prescription of 6 anti-anginal drugs, despite all these previous forms of revascularization. And what we need to do is understand the patient's objective and use the different sources of treatment options available to us to, in combination, these things are not used in isolation, in order to be able to get the patient to the targets that they want to achieve to improve their quality of life. This is a patient-specific management plan. And we have to think, what are the options that we have currently for the treatment of our patients, and understand the benefits, but also the weaknesses of them. And the reality is, despite the array of different anti-anginal medications that we have, 70% of patients still continue to have limiting angina at 12 months, despite optimized medical therapy. In addition, Revascularization is also not without its limitations. Between 20 and 40% of patients continue to have anginal type chest pain despite both percutaneous and surgical revascularization. So we need to consider our choices of treatment, and when we're considering the next phases of treatment, new treatments should be efficacious and address the symptom and the patient priorities. They need to be done at an acceptable level of risk, i.e. safely. The procedure should not incur significant morbidity, and the treatment effect should be durable. And the question is, how can we address some of the limitations of effective treatment? And I think I've clearly demonstrated that there is a clear unmet need for these patients. We need to demonstrate that our procedures are feasible and efficacious and that they can be done safely for patients. So just to finish with where the story of this patient. So she was a young patient who, after extensive discussion in our angina heart team, ended up with a reducer implantation. This resulted in a significant improvement of her symptoms. She was able to achieve the things that she wished to. And when we did follow-up imaging, we were able to demonstrate significant improvements in myocardial perfusion. Those are things that, the perfusion and the change in the CCS class, that's all terribly important to us. But what did it mean to the patient? Well, actually, this lady's father, who was living with her, had a cardiac arrest. She was able to continue with bystander resuscitation for her father till the paramedics arrived without the generation of angina. And so the resolution of these symptoms really, I think, or this case indicates how important symptom improvement is in terms of improving not only the quality of life for patients, but also for their wider families. And now it's my colleagues will tell us how to do it. Thanks very much indeed.
Ranil, that's great, and really quite a remarkable story to end on, that after the reducer implant, she actually saved her father's life by doing CPR. And I mean, I know you're a keen trialist, so my question to you is that an endpoint?
We'd have to do a seriously large study to power it for that.
So, I mean, I know there's questions from the audience, but I think one of the challenges that we face as a community is the dispersal of these patients, that they're not focused in any one point. And maybe I could address that with you, Ranil, first, because you've done a tremendous amount of work to set up a focused angina clinic. How do you spread the net far enough to capture the right patients?
Well, we've been running this clinic now for about 12 years. So really, and so it's through being able to offer a multidisciplinary approach to the care of these patients, and that the management of patient symptoms there's a lot beyond just simple ischemia management, but of course Reducer is a very important component of that. When we introduced Reducer into our program, number one, we observed in our clinical practice significant improvements. But we also had the ability to participate in the randomized controlled trials and registries that provided us non-anecdotal evidence, right, that this was an efficacious procedure. And our referring physicians who sent patients to us also noticed the benefits in these patients, which then grew the network. So I think it's participation in, first of all, careful patient selection, careful patient follow-up after the intervention, communication to your referring colleagues, and then through educational activities and just spreading the word, number one, through presentations at meetings, publications, and the educational events such as this, so that they also appreciate that there are options for these patients. And a lot of patients who, with this kind of problem, many physicians often feel that I really have got nothing left to offer, but actually there are plenty of options to help these patients.
Go ahead, yeah.
If I could just briefly only refer to running to your slides on this fluctuating curve of the anginal symptoms over the course of life, because it pretty much resonates with my part of follow-up in the presentation. Indeed, when we ask the patient if you have or not have angina, we need to also know what activities he or she does, so that we just not only fight with angina, but we want to bring them back to their normal life here, yeah?
So personalizing care in terms of the treatment option you're going to offer to patients, but also personalizing it to the objectives that are important to the patient is absolutely key. Some people will want to go jogging, running, playing golf. Others, like this lady, had much simpler and less ambitious objectives. So absolutely, tailoring what we want to be able to offer to the patient and to the things that are important to them is absolutely crucial.
Okay. Brilliant. Thanks, Rana.
So now we're going to go to James Spratt, and he's going to tell us how the reducer may work and how the mode of action is actually going.
Thanks, Felix. It's always been a dream of mine to introduce myself. Sorry, you've just taken that dream away from me.
I'm sorry.
But thank you anyway. So I'm going to talk about the mechanism of action of reducer, and this is a work in progress, and many people in the room, Ranald, for example, Francesca, I can see you in the room as well, have contributed to this journey. It is an ongoing journey, but it does tell us a little bit how we can optimize the therapy. And I think it does talk to us this as physicians, we like to be able to get our hands around the problem and say, okay, I understand how this works. Therefore, I believe in it. There's an element to this, and you probably didn't think I was going to start with the formula, but this is a very common drug which we use all the time. It's one of the commonest prescribed drugs in the world, and we really have got absolutely no idea how it works, but we know it works. This is actually metformin, which is used to treat diabetes, of course, and has been shown to reduce malignancies and cardiovascular disease and all sorts of incredible things, but we've really no idea how it works. And that's often because the biology that we deal with is so complex and adaptive that it's quite difficult to be too reductive about things. We can remember we're doing an input, but the output is very challenging to predict on occasions. And angina, as Randall has so beautifully shown from the last slide, is a pathway. It starts with a signal from the heart and it ends up with an output from the brain, and we're only really intervening at one part of that signal, and it's no wonder that we find it very difficult to modulate angina, and so many of our treatments are limited. And that desire for understanding with physiology, you can see for FFR as a classic example of that, where we try to demonstrate angina as a single reductive model. Epicardial stenosis, increased resistance to flow, compensation from the microcirculation, this vasodilatation, up to a point where it can't compensate anymore, and then you get either decrease in flow or at least decreased coronary flow reserve. But of course, things are a lot more complex than that. It's just that helps us on the pathway to understanding. So to get to the answer of why the reducer might work, we have to zoom out a bit and think about how a heart works in a normal environment and ask ourselves the question, well, how is flow maintained in a normal heart, and are there components within the normal heart? So the first thing I'd like you to consider is the difference between the epicardium, where most of the coronary arteries run, and the subendocardium, which is the inner surface of the myocardium. And the major difference, of course, is that the endocardium is exposed to pressures within the cavity of the heart. And there is actually a difference, of course, between normal epicardial flow in systole and diastole. But the key concept here is that there's a differential difference between the epicardium and the endocardium. And that differential difference is dominated or driven by the pressure within the ventricle. So if you look at normal flow between epicardium and endocardium, you'll see that this differential difference in terms of vasoconstriction is not that marked, but you see it's slightly exaggerated in the subendocardium, but not to a significant degree to lead to any pathology. Obviously, epicardial flow is diastolic, you all know that. So the constriction occurs primarily in systole, and it's exaggerated in the endocardium. But everything happens in terms of the signaling at a capillary level. That's where the oxygen exchange is and so on. And of course, like everything in physics, fluid goes down perfusion gradients from high pressure to low pressure. And the less the perfusion gradients in general, the less the flow. But in a diseased heart, things change a lot. Obviously, we kind of know that obstructive coronary disease, and we're talking about this primarily today, is the primary reason we see patients in our clinic with angina. And this increased friction to flow cause ultimately, once you auto-regulate it, a reduction in perfusion pressure. And critically, this is where you see the impact of the subendocardium come into play because of that reduction in flow. So once again, if we look at this difference, this auto-regulation can compensate, but it's the point where it fails to compensate that patients get angina, where they fail either due to a problem with the microcirculation or due to a severity of stenosis, that they can't further compensate for this reduction in perfusion pressure. And of course, often this is due to factors like hypertension or left ventricular dysfunction, where you get this rise in pressure within the ventricle, and this compression that we see in systole is actually exaggerated in the endocardium. So you can see epicardium at the top, endocardium at the bottom. And remember, everything is flow mediated. So higher resistance means less flow. So if you're a blood cell and you're trying to choose where you should go, and remember the demand is the same in both parts of the things, you're going to go where there's less resistance. And that means critically that flow will go preferentially to the epicardium over the endocardium. So if you're going to see ischemia, you're going to see it first in the endocardium because of this pressure differential. And that means reduced perfusion back down to the capillary level, and ultimately that means a higher signal given, and therefore, of course, we translate the signal as angina. And we can see this across imaging studies. So that's the pathophysiology, which is well established and well evidence-based. The question that we're here to answer today is, well, how does the reducer work, or how might the reducer work? Does it redistribute flow? Now, the first question I asked myself when I saw this question about flow was, can you increase flow? And the answer to that, it seems quite intuitive, that you shouldn't be able to increase flow, because remember, you've got a microcirculation that's maximally vasodilated, whatever those limitations are. And in these refractory patients, we're saying we're not improving epicardial stenosis. So we can't change absolute flow, but can we redistribute flow to the areas that need it most? And we established already, I hope, that area is the subendocardium. So what the reducer does primarily, or what it should do if it's implanted well, is increase resistance to venous drainage. So in other words, there should be a pressure gradient across the reducer where it creates this back pressure effect. And the best way, I think, to conceptualize this is PEEP, or positive airway pressure, where you create a gradient that actually reinflates alveoli, and that then augments inspiration. So even though you're creating increased resistance, it results in a funny way to decreased resistance, because you reinflate the capillaries in the right area, if you like. And therefore, of course, you're not increasing flow, you're just redistributing flow, because you're changing the pressure differential that was previously there, or at least in a positive way, between the epicardium and the endocardium. Now, that's all very well. We can chat about whether it works or it doesn't work, but we've really got to evidence some of these things. We've got to have some evidence that supports that hypothesis. And Orbit Cosmic, which of course was a sham control study, did look to answer some of these mechanistic questions. And the first question they asked was, well, does it increase total myocardial flow? And I always thought that didn't make any sense to me. And that was the case. There was no difference in total flow, and really, how could there be? But was there a difference in regional flow if you stratify it according to ischemic or non-ischemic? Well, actually, you could see that there was this redistribution to ischemic areas at stress between the endocardium and the epicardium. So in some ways, what we were doing was redistributing flow to the areas at most need by this back pressure effect. And that was highly significant in terms of the probability of benefit from the Bayesian analysis. And if we go back to what you're essentially doing is creating a stenotic gradient, so the venous drainage is part of that is the implant itself, because it's an R-shaped stent, but part of it is the endothelialization. And you might therefore hypothesize that the benefit might not be, maximal immediately, but it might improve over a period of time. And in fact, you did see that at 3 months. So we're left with this, what seems to be a cogent hypothesis, that if we increase the pressure gradient, we end up redistributing flow from epicardial to endocardial. So rather than augmenting flow, it's flow redistribution. And I'm going to stop there because one of our panelists is a real expert in this area, Ranald da Silva, and he's done some up-to-date work. And I'm going to give him the opportunity to tell you about that. And of course, any questions are welcomed.
Fantastic. So we, as part of our evaluation of patients with Reducer, were clearly interested in what is the mechanism of action. And actually, what we did was we looked to our patients who were getting Reducers, and we did perfusion imaging for them. And we did perfusion imaging in 2 ways, either by MRI perfusion or by rubidium-82 PET perfusion. Now, the important thing about these 2 modalities is that these are quantitative measurements of myocardial blood flow. These are not just simply visual adjudications of defects on the perfusion scan, which is the conventional way that we evaluate non-invasive ischemia. And we demonstrated, just to cut a long story short, 2 things. First of all, that if we could go back one, James, if that's all right. So it was redistribution of myocardial blood flow, but it was not only from towards the endocardium, as James has demonstrated and shown in Orbiter Cosmic, but we also show redistribution of perfusion across myocardial segments. And we showed this both by PET and by MRI. But importantly, the greatest effects, the greatest improvements of perfusion were seen in those areas which were most underperfused at baseline. So here's a couple of examples of pre and post Reducer implant. On the left panel, you've got PET, and on the right, cardiac MR. And you can see on the left hand, on the PET scan, you can see those changes in perfusion that are happening particularly in the apical segments, and in the cardiac MRI scan, where on the left-hand side are rest measurements, on the right-hand panel, stress measurements before and after Reducer implantation. Blue is lower areas of myocardial blood flow. Orange is higher areas of myocardial blood flow. And you can see that the amount of improvements in myocardial blood flow, particularly stress flow, that increases after Reducer implantation. So the changes in perfusion reserve that we see, maybe the next slide, James, is that if we can stratify, right, the areas which are most likely to be underperfused on the basis of a reduced perfusion reserve. So by PET on the left, an MPR less than 1.8, those segments improve their myocardial perfusion reserve. These are the most underperfused segments, and you see that by both PET and cardiac MRI. But in those areas which are better perfused, that actually the MPR goes down, indicating, yes, total flow hasn't changed, but we're just shifting perfusion to where it needs to be. And that the magnitude of shift is dependent on the severity of the baseline flow, and I think that's shown in the final slide. And to show this, and the next one, James, to show this linear-ish relationship between baseline perfusion and the change in perfusion after reducer implantation. So it is a question of perfusion redistribution to the areas that need it, and it's not just from endo to epi, but a segmental change in perfusion into those areas that are most underperfused at baseline. At least that's our hypothesis right now.
Yeah, I think that's great. I mean, I guess, when you're looking at any evidence, Randall, one of the things you look at is consistency and reproducibility. Where do you think we are with that question at the moment?
Well, I guess the fact that we got very similar observations by two independent methodologies, both PET and MRI, that's a good thing. But when we're adjudicating or choosing out the methods by which we assess the effectiveness of these agents, we have to show that the measurements that we are making, number one, are accurate, and number two, reproducible. Because what we don't want to have are methods that we use where the reproducibility is so great that we either are unable to detect a change or we detect a change due to a play of chance rather than actually due to a pathophysiological change as a result of the intervention.
James, we took away your chance to introduce yourself. Now we take away your chance to ask yourself questions as well. Felix, you probably have something. Because I have a tough one.
So we have a couple of cool questions about the implantation and the medical therapy afterwards. We're probably gonna go there after we have heard Mario's talk. There's only one question is about maybe additional collateral forming if there is a CTO and a coronary sinus reducer implanted. Any thoughts on that?
Yeah, well, changes in segmental perfusion through collateral seems like a very plausible mechanism of action. And that's one thing. And the second thing that we know is from the observational data that we have so far, that reducer implantation seems to be particularly efficacious in patients who have CTO. So, yeah, I mean, it makes sense.
Tommaso?
I do have a tough question. I don't know if you want to moderate me before I formulate it. So you mentioned the autoregulation phenomenon, and you said that autoregulation is exploited in those patients. And the other factor is that you're not going to affect with this device, unless you say the opposite, you're not going to affect the compressive forces. You're not going to affect the left ventricular end diastolic pressure, potentially, unless you contradict me. So my question is, what do you think that is the parameter that you affect? You affect resistance in some parts of the circulation, specifically those that are ischemic, because they have a higher resistance. Do you affect the capacity of specifically in that part of the microcirculation, to increase flow upon increased demand? So essentially, my point is, what is if you want to have an endpoint to measure the effectiveness of the reducer, is it resistance or is it coronary flow reserve?
Yeah, I mean, I think that's a great question. There definitely are a few missing links in the MOA data as far as I can see it. We're looking macroscopically at flow, and we're using flow as a surrogate for ischemia, or ischemia in itself. And I think probably one of the things we definitely have to do is connect the trans-reducer gradient to a change in physiological matrices, because it's very difficult to hypothesize any physiological effect without a change in gradient, change in venous gradient. And I think there's certainly a kind of gap in the evidence there. There's a very obvious way to answer that gap, but I think it may also start to address the question that people often ask about why does it not work in 20% of patients, and how can I target those patients or change that environment? So I think there's still a lot of more work to do. So, having said that, on that bombshell, as they say, we'll go on to the next talk, and Marius is going to talk to us about, well, we've said, for example, there's a need, that the MOA is at least hypothetical in the right lines, but if we do commit to this device, is it a complex thing to do, and how should we go about doing it in the optimal way?
Thank you, James. Many thanks for having me here today for this interesting symposium. My name is Mariusz Tomaniak, and I represent the University Clinical Center of Medical University of Warsaw, based in Poland. Let me start my talk by sharing with you this 76-year-old female patient with CCS-free angina. Despite optimal medical therapy, she underwent several interventions, both percutaneous and surgical, and at some point, heart team decided to qualify her for conservative management. She had her anti-anginal medication extended and up-titrated. However, she still experienced debilitating angina that severely impacted her quality of life. Therefore, we qualified her for coronary sinus reducer implantation. And I did it following this simple four-step approach, which I will briefly overview with you now. So, first, we prepared the patient, and it's good actually to reposition the typical cath lab setup so that the scrap table was actually perpendicular to the patient in the lab, and so that the operators, or like in my case, me and my nurse, are to the right of the head of the patient that we treat. I take the camera LAO 30, and I do ultrasound to guide the right internal jugular vein access. Once I have the sheath already in the right atrium, I measure the pressure, which should be confirmed to be less than 15, we expect that the device efficacy with values above the 15 would be less expected. In majority cases of the cases, it's really below the 15, and here it was 7, so I could proceed with the implantation. So, to do so, I engage the coronary sinus with MPA catheter. No push here, just with subtle rotation. I direct this catheter to the 4 or 5 o'clock, and once I'm at the ostium, I advance it further with a J-wire to optimize the position of the MPA, do the angio, and while evaluating the angio of the coronary sinus, important anatomical factor is the venous valve. I will come back to this in a moment. We keep in mind two facts: that the size profile of the reducer device is between 9.5 and 13 millimeters, and that we do intend to oversize the device approximately 10% to confirm its stability in the place that we wanted it to be. So while implanting, we have to a bit of weigh the trade-off between the safety and efficacy, because the more ostial we go, the more myocardial territory we treat. On the other hand, the more ostial we are, there is potentially somewhat higher risk of device migration. On the other hand, if we go too far away, too distally, then we actually manage less side branches and less myocardial territory, so this could be potentially less effective. So actually, this sweet spot for the implantation would be around 2 centimeters from the ostium of coronary sinus. But what is most important, we do want to have the neck of the device exactly over and above the natural anchoring points, which is the venous valve. This venous valve, when it's in the neck of our device, it stabilizes it, but it also facilitates endothelialization of the device so that we could expect even earlier symptoms relief in our patient. So I proceed, I rewire coronary sinus with a J-wire, position J-wire in a distal coronary sinus branch, heparin, and we proceed with the deployment. Here, so-called mother and child technique. So with the J-wire distally, I position MPA as distally as safely possible and advance 9 French guide catheter carefully over the MPA. I want to be distal to the plant implant site. it's good when when I'm already there, I can proceed with advancing the delivery system of the reducer. It is good to stop with the reducer already in the right atrium, just to confirm that I have the device between the first and the second marker band, as you can see here marked in red on this video. So I advance the device to the desired location within the 9 French guiding catheter. I retract the guiding catheter to the most proximal marker band. And once I have just had this device in place, I can start with the inflation. The inflation pressure, initial inflation pressure is usually 2 to 3 atmospheres. But what is important here is that I check the oversizing of the device. I just give a flash with the contrast here to check that there's already oversizing there. And for this lady, this 3 atmospheres was actually fine to achieve this 10% overexpansion. So I have the device implanted. Now my goal is to retract the balloon. To do so, it's quite important to expel all contrast from the indeflator, and it's also important to have in the indeflator a mixture of the contrast plus saline. It should be actually diluted with saline. We should suck it out at least 3 times, and actually this time of sucking the contrast out from the system is quite relevant to perform it smoothly. It's good to be patient at this step to ensure a smooth run of this procedure. And then we advance the. I use the right hand to just gently pull back on the balloon catheter, while with the left hand I advance the guiding catheter until the tip is at the opening of the reducer neck, which you can see on the graph in the corner. I have the guiding just at the neck of the device, but I do not want to have this guiding further than the neck of the device. And so once the whole balloon is already in the guiding catheter, I can take this completely out away. So now I reinsert MPA through the device just for final angiography, confirm position, confirm the desired around 10% oversizing, and the absence of any complications like perforation, dissection or displacement. I prescribed for this lady DAPT for 3 months, comprising aspirin and clopidogrel, and then she continued to aspirin lifelong. So we follow up her, as we usually do in our outpatient clinic. We bring all our patients back at 1 month, 3 months, 6 months, and 12 months post-procedure. And we were happy to hear that she is actually angina class 1 at 3 months and at 6 months post-procedure. And this was also visible in the dedicated angina questionnaires, Seattle Angina Questionnaire, which you can see here. The more points you have here, the better you are with regards to the angina. So this is how we do it in our outpatient clinic. We routinely give these questionnaires to our patients at these time points. We also perform exercise testing at 3 months post-procedure. We do a medical therapy check because some of our patients can have their anti-anginals just withdrawn or those reduced. And as an option, but we in our center for research purposes do it routinely as well. We do a follow-up echo, magnetic resonance imaging, and invasive microvascular assessment. And to summarize, I also wanted to briefly comment on the building of angina program and the establishing of effective referral network. In particular, I wanted to emphasize here how critically important it is to keep in the loop of information the general cardiologists that referred the patients to us, to you, to your angina clinic. It is routine for us just to report both the acute result of the procedure, but also the 3-month follow-up with regard to the symptoms relief, not only to the patient when we talk with him or his family, but it's important to each general practitioner, each general cardiologist that refer the patient to us. I say to my team that keeping the loop actually builds your group of patients that you can treat with this therapy. And in my experience, that really encourages this general cardiologist to refer to this therapy. They know, they're aware about the outcome, about the safety, and the potential angina relief, and they refer even more patients themselves or their colleagues, which they speak with each other. So this good news are spreading by the word of mouth. In other words, it's not just between us interventional cardiologists to do a fancy procedure. We do need to keep in the loop of information all these general cardiologists and even GPs to encourage and to reach out to these patients who are not infrequently consulted for several months or years for angina, that the things have changed, and now we have a device that can be actually safely and smoothly implanted using this four simple step approach. Thank you for your attention.
Marius, that was great. Any questions from the audience on Marius's excellent, very clear presentation? We're sort of on the go for it. Grab yourself a mic. There's one just behind you there.
So there's a couple of questions you have been asking. So what are the possible complications? And what about device thrombosis? And what are we going to do if there is a CRT planned or a CRT needed?
Sure. So these are also the questions that I'm asked about all these general cardiologists. So for me, the most important thing is that there is no thrombosis here. This is absolutely critical for me to think about this therapy. We remember from medical studies that the Virchow triad, that if there is a venous site, slower flow potentially, there could be the risk of thrombosis, but since there are already long-term follow-ups of reducer therapy, there were no thrombosis of the device, which for me and for our general cardiologist was really, really reassuring. So I think this is a very important and critical point to remember about. For the potential complications that could occur is naturally the dissection of the coronary sinus, either during device implantation or just due to wire positioning. We do have to remember to put the tip of the wire in the great vein. So it should turn left to the vein that is draining LAD. We should rather not have it in the marginal branch that is draining left circumflex, because this is the most safe approach to do so. And for ICD, still we need more data, definitely, but there were some cases, reports showing that we can actually implant the electrode already across the reducer, keeping the reducer there and having effective chronic resynchronization therapy.
Yeah, thank you for the great presentation. Two questions, one technical and one clinical. Technically, how would you easily select and go into the coronary sinus? And the other question regarding the selection criteria, who will most benefit from that device?
Sure. So as interventional cardiologists, we are more used to definitely to work on the arterial side of the heart. So it's important to get used to but you have to remind yourself the anatomy, guide the MPA to around 4 or 5 o'clock, I would say, the direction. And just when you are having this guiding at the ostium, with the wire you can proceed with further. It's important not to have a kind of a belly sign, which is a huge curvature of the catheter. If your catheter is just having such a shape, C shape, then it means that you will not manage to catheterize the ostium of the coronary sinus. You should withdraw it, turn right, left, so that it could be more feasible. Regarding your question, who can mostly benefit, these patients have really typical, so for the large group, the largest so far is, in our experience at least, are these patients who exhausted all these medical therapy options and the interventions, CABG, closed grafts. So they do benefit here, But really, according also to our experience and already discussed studies during this course also as well, and I'm sure that also Tommaso Gori and Daniel will talk about it, we have a huge improvement also in patients with coronary microvascular dysfunction. We already see this in ANOCA patients, that they do have increased coronary flow and reduced IMR assessment, which is quite striking. Of course, further studies are warranted here. We also run such study in Warsaw, CSR ANOCA study, but this is also population that definitely could benefit from this therapy.
That's brilliant, Marius. In the interest of time, I think we'll just thank you again for an excellent presentation. And we'll go on to the final talk in the symposium. Tommaso Gori is going to take us through the clinical data, including a patient testimonial video. So Tommaso, looking forward to this one.
James, thank you very much for the introduction. So having addressed the need, the potential mechanisms and the how of the reducer, I'm called to address your thirst for numbers and data. But let me start with a first and finish with a slide where actually no data, no numbers are presented. So the first concept that I would like to reiterate, and Ranila said it already, is that in 10 to 15 years, I will probably have grandchildren and I will have angina, unfortunately, probably. Now, I'm not sure in what order, temporally, and in what intensity, either of them. But my treating cardiologist, in his good intentions, will be interested into measuring the outcomes of his treatment. Of course, I'll be interested in mortality, I'll be interested into revascularizations, but I will also be interested into whether I can play with my grandchildren, whether if I will still work, whether my job will be affected, whether I will be able to spend time with my wife if she hasn't divorced from me before, but that has nothing to do with angina. So the truth is that 35% of the patients that have angina report that this symptoms has a significant impact on their quality of life. And quality of life is a little bit more evanescent. We don't measure it. Actually, we hardly measure it. We don't read it in the papers that we read. And this is what Ranil already said. But this is a debilitating condition. This affects the quality of life of the patient. And the patient see it as an endpoint to have a good quality of life. And I come back to that in the last slide. So we have patients with severe angina. We have patients that are being treated with standard medications. We have patients that are being revascularized with standard methods. And then there are patients that have ischemia. And I actually like to present this slide in the reverse animation because patients and we don't understand really fully what the relationship between ischemia and symptoms is. It is very complicated. Angina and ischemia are complicated phenomena, and our understanding is incomplete. But still, we need to address the quality of life of those patients, and we need to address it in an individualized way with a treatment that specifically treats the patient and not just follows an algorithm that is the same for every single person. So what are the key outcomes that may define the success of my cardiologist in 15 years? Of course, I want to have something that is feasible. I want to have something that is safe for me as a patient. I want to have something that is efficacious, that allows me to play with my grandchildren or spend time with my wife. Then I want to have this effect to be durable. I want to have several years of good quality of life. And then, of course, looking back at myself 15 years before, it would be nice to know how it works. And it would be interesting from the academic perspective as well. I hope that in 15 years I will be still able to be interested in something. So, is implantation of a sinus reducer easy and feasible? And the answer is absolutely yes. There is more than 1,000 cases having been reported and published, and the success rate is above 90% in all studies. There are more complicated cases, there are less complicated cases, there are cases that end up in a half an hour or 20 minutes, there are cases that last several hours, but this is true for every single procedure that we are involved into. The final success is the same in all publications, above 90 to 95%. Is it safe? What are the complications? This was one of the questions to the previous speaker. The rate of complications is very similar to that of whichever safe stent implantation that we are used to do, and we do thousands or millions per year worldwide. All the studies published a rate of complication in the range of the very, very low single-digit percentages. Of course, the smaller the number, you see an 8% there, the smaller the number of the patients enrolled in the study, the larger the weight of every complication. So this 8% are down there are 2 embolisms in a study that recruited 24 patients that have been treated. And still, embolism, I don't remember if it was mentioned before as one of the complications, is not a real complication. So the size, the volume of the reducer is so small that at the end you may as well leave it in the pulmonary circulation, nothing happens, doesn't cause a thrombosis, doesn't cause a lung embolism, doesn't cause a reduction in flow in the lungs. The one complication that is that may be feared is the one to the very right, periprocedural stroke, and that has nothing to do with the implantation of the device. It has to do with the puncture wrongly of the carotid artery instead of the jugular vein. So it has nothing to do with the procedure. It may happen in every single patient that we instrument in an intensive care unit, and we do it several times per day independently of the implantation of a reducer. Does the device work? And here I will present some data. This is a device that has 2 sham-controlled studies, and this is a unique case in the whole cardiology, essentially. The sham-controlled studies were run into patients that really had symptoms. They were young, 67 years of age for COSIRA, the first study. They had been treated with intensive therapies, CABG, previous PCIs in 3/4 of the patients, no revascularization more possible. They had been very symptomatic for several years in many cases, so 100% of them with CCS class 3 or 4 angina. And despite maximal therapy, they had refractory symptoms despite the optimal medical therapy. So those are the results, the top results. And as I said at the beginning, it is hard to quantify quality of life. It is hard to quantify how much a patient can play with his grandchildren. And the best way that we have is Canadian Cardiovascular Society class. So this is the control and reducer group at baseline. And this is the control and reducer group after 6 months. So as you see, the light colors are significantly more frequent in the reducer group. 71% of the patients in the reducer group improved by at least 1 CCS class as compared to 42 in the control, a significant difference. And 35% of the patients improved by 2 CCS classes as compared to 15% in the control group. I repeat, this was a sham control trial. Neither the investigators nor the patients knew which group they were adjudicated to. These results have been confirmed by several studies and meta-analysis. The chance that a patient improves by at least 2 CCS classes, also in registries, large studies, is about 40%. And this is way more than what OMT does. It is also more than what a stent does. So I'm not really worried about non-responders. It is interesting from the academic perspective that this is more than what stents do. So if you don't worry about non-responders when you implant a stent in the mid-LAD, you shouldn't be worried about non-responders with a reducer. The Orbita Cosmic has been named already. It was the second placebo-controlled trial. And here the authors made an effort at quantifying quality of life and angina with this Orbita app that where the patients give in daily what symptoms, what degree of symptoms they have. Now I can go straight through it. Same type of patients with severe disease, young and willing to be treated and willing to have a good quality of life. And the dark red is the amount of angina episodes that they reported. As you see, the dark red is abundant in the placebo group, sham-controlled group, and less frequent in the coronary sinus reducer group. So even here, an odds ratio of 1.4, that means a 40% chance to have an improvement in symptoms, CCS2, which leads from the couch to exercising, basically, and the quality of life. So the mode of action has been discussed already. There is a rationale for those effects. It's not just observed phenomena, even though very formally observed phenomena. There is a reason why they occur. And there's also a reason, as James showed, why those effects are maximal upon endothelialization, so about 2 months after the implantation, and why they persist over at least 3 years after the implantation and stay constant upon 3 years after the implantation. 5 years later are still being collected. So the data is consistent. There are nuanced differences. There are some differences across different trial designs and patient populations, but it is clear that procedural success is high, that the change in CCS class is extremely high, 40% at 2 CCS classes. That means from not being able to raise up from the couch to being able to do exercise or play with kids. And the mode of action is confirmed. Now I want to go to the last slide, which is a patient story. When I was asked to provide a patient story, I was a little bit wary. I was a little bit indecisive. I dislike making advertising, to be very sincere. I like presenting data. I dislike even more my patients to make advertising and exposing them to the risk of making advertisements. Now, this patient that I'm presenting now is a patient that we treated with the sinus reducer. She came from far away from my institution. She came back at 6 months for the routine control. I didn't see her. She came to the clinic. But the day after, she called me and she said, I wanted to thank you. I didn't see you yesterday. I wanted to thank you personally because my life has changed. So I thought this might be the right person to present. So there is a video. I cut away all the parts where I'm in it, so it's okay. And it's 2 minutes, which I hope you will enjoy. It's in German with subtitles.
Mein Name ist Gundel Grohmann, ich bin 78 Jahre alt und hatte das Glück, dass ich mit 57,5 in den Vorruhestand gehen konnte. Und das habe ich auch genutzt, da ich mit 49 Jahren mit einem Kammerflimmern beim Kardiologen umgefallen bin. Ich habe seit meiner Geburt Asthma und 2001 kriegte ich dann den ersten Stent. Und so ging das dann weiter. Ich habe insgesamt, habe ich mal nachgezählt, bis jetzt 18 Herzkatheter gehabt, bis ich dann 2024, ja, im Mai 24, dann nicht bloß einen Stent gekriegt habe, sondern einen Sinus Reducer. Die Stents haben mir immer weitergeholfen und dann war wieder der Moment da, dass ich nicht mehr so richtig gehen konnte, dass ich, ja, wenn ich den kleinen Weg hier runtergegangen bin, die 100 Meter, bin ich einmal stehen geblieben zu einer Freundin, die auch nicht weit weg im Dorf wohnt, musste ich 5-mal stehen bleiben. Und dann war ich wieder beim Kardiologen und der sagte mir, ja, sagt er, ich weiß jetzt auch nicht, aber in meiner Fachzeitung gibt es einen Artikel über ein neues Verfahren von Professor Gori. Ich hatte keine Beschwerden danach. Ich merkte, als ich aufgestanden bin, am nächsten Morgen hat mein Mann mich um 10 Uhr abgeholt und dann merkte ich schon, wie das Gehen auch leichter wurde. Und während er den Reducer gesetzt hat, wie die Menschen da miteinander umgegangen sind, wie er mit seinem Team umgegangen ist und das Team mit ihm, also für mich war das schon toll. Bin froh, dass ich das gemacht habe und ich denke, es hilft mir immer noch. Ja, und hier zu Hause habe ich das sofort gemerkt. Es war also schon eine Erleichterung, wieder laufen zu können, ohne alle 5 Minuten stehen zu bleiben. Merkte auch, dass die Kraft immer ein bisschen mehr wurde. Und dafür steht dann auch mein Lebensring, den ich immer umhabe, den ich zu nichts ablege. Weil dieser Ring, den hat mir mein Mann nach der Herz-OP geschenkt. Und das ist, ich denke mal, solange das alles heil ist, dann bleibe ich auch heil.
Hang on a minute, what's she doing there? So an ice cream. Nobody told me there was ice cream in this.
I think I'll stop. Please believe me, it is painful for me to have been in it.
She was doing all right up to the ice cream. So, I mean, Tommaso, that's brilliant, and I understand we've craved your indulgence by running over a little bit, and I think that was very much worth it to see, of course, why we all went into cardiology, to help people get better, not to help them have ice cream, by the way. So a big thanks to everybody on the panel and for you for a great session.